Well, thank you for joining us this morning for this week's PGY2 Pain and Palliative Care webinar series. Speaker this morning is Dr. Bradley Rea. He's with the Hospice of Southern Illinois and completing his PGY2 at that institution. Our topic for this morning is Complex Regional Pain Syndrome, or CRPS, previously known as Reflex Sympathetic Dystrophy. And for those of you on the webinar, the link to the recorded Zoom will be hosted on the Society of Palliative Care Pharmacists website after completion. So with that, I welcome Dr. Rea and thank you for joining us this morning.
Thank you, Dr. Hernan, for the introduction. So, as you said, I'm going to be talking about complex regional pain syndrome, or CRPS. And I guess one of the reasons why I chose this condition in particular is because in November is actually Complex Regional Pain Syndrome Awareness Month. So I think it's a good kind of lead into why I would choose this topic. And you can see from the pictures here, it is a disease that does cause physical malformations in chronic cases, which can be extremely detrimental to patients' quality of life. It is actually rated as one of the most painful sensations and painful conditions that a person can go through, even more painful than childbirth, which I will show you a pain scale here in a little while that kind of goes over the different pain levels that we associate with different conditions and how this relates to that. So kind of a quick history about it. It was first described by Silas Weir Mitchell, and he called it causalgia. And that was during the American Civil War. And it was called causalgia because it was known to cause both pain and heat. So there have been to date about 67, or there have been estimated to be about 67 different English terms used to describe CRPS. Complex regional pain syndrome is the latest term, but before that, one of the terms that it was commonly called is reflex sympathetic dystrophy. There are some historical figures that have been diagnosed with it and have been either cured of it or they have been passed on. One of these cases was Howard Hughes. They have a movie about him and etc. But he essentially was a guy that rode a lot of planes, and he actually developed CRPS from a plane crash. And then another prominent case, or another prominent person that was diagnosed or supposedly diagnosed with it, was Paula Abdul. She actually underwent therapy and is no longer considered to have it. Although one of the risk factors with this is that once you do develop the disorder, even if you are cured from it or you have resolution of it, you are at an increased risk of having this disorder flare up again. So how common is this disorder? Well, there's about 5.5 cases per 100,000 patient years. So it is expected that about 20 to 80,000 new cases of CRPS should be identified each year in the United States. It does increase in incidence until about 70 years old, where the incidence somewhat falls off. Women are more likely to develop the disease, about 3 to 4 times more. Not only that, but when they do develop the disease, it is also typically considered more of a painful sensation or more extreme pain than if a male develops the disease. As far as where the disease develops, typically it's either your arm or your leg for the presenting factor, and it's usually unilateral. That isn't to say that it can't transfer over ipsilateral to your other limb, but it usually starts off in one limb, and it usually starts off with some kind of initiating or triggering event. The arm is about 60% of the cases, while the leg is about 40% of the triggering event. About 45% of the cases that actually trigger the event are due to fractures, about 20% are due to sprains, and about 15% are due to elective surgeries. All the other percentage points that I haven't mentioned are due to other cases, whether it be a different type of musculoskeletal injury or some other condition. So spontaneous development of CRPS accounts for less than 10% of the cases. So usually there is a triggering event. Usually it's not idiopathic as far as why patients develop this disorder. As far as some risk factors, interestingly enough, the severity of the trauma that a patient has does not influence their risk and does not increase their risk. So it doesn't matter if you break your femur or you break your pinky. the risk is identical and it doesn't matter as far as the damage or as far as the pain goes. As far as psychological profile, there have been some studies to assess if anxiety and depression as co-occurring conditions prior to the development of CRPS are risk factors. And there is some varying results, although it does seem to tend that patients that are anxious or depressed prior to the development of CRPS are more likely to develop the disorder. There was a study in 2009 that actually assessed antihypertensive medications and the risk of developing CRPS. And you can see here I have ACE inhibitors listed because they were the only medication as far as antihypertensive went that actually increased the risk of developing CRPS. They also looked at angiotensin receptor blockers, as we know, a very similar medication to ACE inhibitors, but they did not find any statistical significance in actually development of this disorder. It is not only that they are on an ACE inhibitor, but other factors that influence the risk of it is the dose of the ACE inhibitor, how long they were on the ACE inhibitor as well, and if they were currently using it or if they had recently been stopped. So it is hypothesized that ACE inhibitors might influence the increased risk of CRPS due to neuroinflammatory mechanisms that underlie CRPS. And that has to do with the interaction of ACE inhibitors with the catabolism of substance P and bradykinin. As we know, ARBs don't really mess with bradykinin, which is why we don't get that dry cough, or we have a much lower incidence of dry cough. There have been studies assessing if immobilization of a limb does increase the risk, and it has been shown that it could increase the risk, although there isn't good data to support that. Some other compounding variables that could increase your risk are migraines, asthma, history of stroke or MI, and smoking. As far as genetics go, there is a genetic component, although it is not very strong. So some patients and families do have clusters of patients that are more likely or have developed CRPS, although we haven't really been able to determine any genes or alleles that actually determine if a patient is at that increased risk. As far as the pathophysiology of this disorder, it's very hard to explain because we don't know very much about it. We know there are multiple mechanisms, both central and peripheral, that do influence the pathophysiology of this disorder. Typically, it starts off more of a peripheral problem and then developing into more of a central problem with a central sensitization kind of aspect to it. So inflammation is typically one of the presenting factors, which has to do with quite a few different substances such as CGRP, substance P, TNF-alpha, interleukin factor 2, and free radicals. And these are going to take somewhat of a role in medication therapy and what medications we are going to use to try to treat this disorder or cure it. There's also vasomotor dysfunction, which typically when you get this disorder, you usually start off with the limb or the area around the limb becoming very warm. This is estimated to last about 4 months, in which case it will develop into somewhat of a mixed case. Some patients stay within the warm area, typically due to hyperperfusion due to vasodilation in that area. We also have the mixed area, which lasts about 15 months on average. And then typically if patients do develop it chronically, they develop what we would consider a cold, where the extremity is typically more cold. In the warm periods, even extreme body cooling was not found to decrease the temperature in the affected limb. So it doesn't actually, it's not influenced by the environment. It is influenced just by the local area. And the reasoning behind that is somewhat obscured, but norepinephrine levels were found to be lower in all stages of this vasomotor dysfunction. As far as the CNS, we do know that there is a central sensitization aspect of it, as we know with many chronic pain conditions that we have discussed in either this webinar or previous webinars. So how does this actual present, or how does this condition present? Well, I will say that it typically presents with a minor or moderate tissue injury. This can be a wrist fracture, this can be an ankle fracture, this can be a tibia or fibula fracture. It could just be a sprained ankle. It's not that one event causes it more than others. It's pretty idiosyncratic in that it doesn't really matter where the injury happens. There just typically is some injury that causes it. And then typically the condition actually presents months after the injury. In the acute phase of this condition, the limb is usually extremely painful. It's red, warm, swollen, kind of like we would expect with a swollen ankle if they had a sprain or something of that nature. A lot of times this can cause epithelial changes, either changes with not only the temperature, but also hair development or nail development, depending on where the condition is actually taking place. A lot of times we have allodynia, so non-painful stimulus causing pain, hyperalgesia associated with it, so a painful stimulation that is evoked with more intense pain than usual. We can also have some mechanical and thermal hyperalgesia, so cold and hot can be extremely painful for these patients. And what typically happens is the pain starts to distribute. And when I say that, it typically does not go outwards. It usually goes more towards the inner parts of the body once the pain starts to distribute through. And as I said, typically it presents as more of a warm condition where the skin is more warm until you develop more of a chronic CRPS condition where it does turn the skin and the temperature around the skin to be more cold. So the pain typically doesn't subside. It usually spreads. However, there are cases where it does completely resolve. If it does resolve on its own, it usually resolves in 1 to 2 years. However, the problem is this condition can essentially last for life. And this typically what happens is like some of those pictures that I showed before where the patients become very contracted. This is some of the later symptoms in chronic CRPS that we can see. Some other problems that we often see are dystonia or tremor that are associated with this. And other things that can happen is it can also spread contralaterally. So even though it starts maybe in your right wrist, it can spread all the way to your left wrist. And as you can see by the McGill Pain Index, this is actually a condition that is one of the highest pain ratings that we know. It is more painful than kidney stones or amputations. It is more painful than childbirth. So there are women that have said that this condition is more painful in childbirth. It's not like it's males out there saying, well, this hurts really bad. I'm sure it hurts worse than childbirth, especially since women are more likely to develop this condition. They are good indicators of how painful this condition actually can become. As far as the different types of CRPS, there's typically 2 different types. There's CRPS 1 and CRPS 2. CRPS 1 was traditionally known as reflex sympathetic dystrophy, and it's typically found that in this condition or this subtype of it, nerve lesions cannot be identified. However, there are some problems with subtypes of CRPS. For example, bone fractures or surgery can damage peripheral nerves, but they're almost always classified as CRPS1. Furthermore, pathological studies on CRPS1 limbs have been shown that they can have degeneration of small c and alpha delta nerve fibers. So it is hard to actually determine before mortem or post-mortem or pre-mortem, I should say, whether they actually have CRPS1 or CRPS2. CRPS2 is commonly called or commonly considered or previously considered causalgia, which is what I talked about a little bit with the history. And this is when a nerve lesion can typically be identified. CRPS NOS, this was typically thought of as being introduced because there have been some diagnostic changes of how we diagnose this condition. It's typically diagnosed on symptoms, but before these diagnostic factors were taken into diagnosed if a patient had CRPS or were diagnosed with CRPS, and they did not meet the diagnostic criteria, they would be put into this group. So how do we diagnose this condition? There's typically 2 ways that we look at diagnosing this condition. There's 2 criteria. The first one is the Budapest criteria, and then the second one is the Orlando criteria. So which one you use is kind of up to you, but much like fibromyalgia, there is no diagnostic test to determine if a patient has CRPS. The diagnosis is typically based on clinical features. And when assessing this, what we're going to assess and what we're going to look at is the clinical diagnostic criteria. Looking at studies, there also is research diagnostic criteria, which is a little bit more all-inclusive. But you can see here for the Orlando diagnostic criteria, it's a little bit more simplistic to be diagnosed with it. And they only have to have they have to have all 4 of those conditions. Now with the complex regional pain syndrome diagnostic criteria for the Budapest, you can see it's much more all-inclusive. And you can see that they have to have at least 1 symptom in 3 of 4 of the following categories here, and they must have at least one sign at the time of evaluation in 2 or more of these categories down here. You also must say that there's not a other condition that would be likely to be causing this complex regional pain syndrome. Right now, these are the 2 best diagnostic criteria that we have for diagnosis. And unfortunately, like I said, like fibromyalgia, there is no diagnostic criteria like laboratory studies that we can do to say, okay, this person definitely has CRPS. It's essentially looking at the symptoms and signs that the patient is experiencing. So moving on from here, we're going to talk a little bit, or I'm going to talk a little bit about how do we treat this. And it is a very complex disease, and it's very misunderstood of the best route of treatment. So there are quite a few different things we can do, and a lot of it is similar to how we would treat something like phantom limb pain. So we can use physical therapy or occupational therapy, mirror visual feedback, we can do medications, and surgery. Typically, surgery isn't recommended, and I'll talk about it a little bit more near the end, but there are guidelines that do assess CRPS, and the treatment algorithm that I will present on the next slide does have some kind of at least guideline to how we should go about treating patients. So it essentially starts off with the first section with mirror therapy, or GMI, which is similar to mirror therapy, but is essentially training the brain to kind of use the limb and understand that the limb and the brain connection needs to exist to help with the pain. There's a lot of different other therapies that are classified in this group, although the data isn't great for pretty much any of these therapies. There's not a whole lot of good data to say the best way to treat CRPS, unfortunately. A lot of it is occupational therapy, physical therapy, mirror therapy, and then medications. And we will talk about some of the medications that do have data in treatment of this, and some of them that are up and coming that may have more data in the near future once more studies start to come out looking at how we can actually treat these. So as far as we go, the medications is going to be our mainstay of treatment, since we are typically pharmacists listening in, or I'm a pharmacist, so I'm going to present on the medications and some of the research behind some of the medications. So they also, in the guidelines, do have different medications that can be used depending on what type of pain they have and what type of symptoms they are experiencing with their pain. So you can see if they do have mild to moderate pain that is excruciating and intractable, we can do analgesics, we can do spinal blocks, we can do opioids, we can do interventional therapies. However, if they have other conditions like inflammation, which is typically more thought about being found in the acute phase than the chronic phase, we can try steroids or NSAIDs. Unfortunately, one of the problems is that they don't have a whole lot of good data, because when this condition was first really looked at as far as treatments go, they thought it was such a complex condition that they didn't think NSAIDs or corticosteroids would be something that would be able to treat it, since it does have not only that peripheral aspect, but also has a central aspect too. So there also is options to use medications like immunomodulators. You can use sedatives or analgesics. Antidepressants do have some data. And then we also have things like anticonvulsants. So this condition, like a lot of neuropathic conditions, are going to have similarities between the different treatments. As you can see here. And as far as the vasomotor disturbances, a lot of the treatments for that is going to be antihypertensive, like calcium channel blockers, sympatholetics, and then other kinds of blockers such as like clonidine or alpha blockers, which do have some data in helping with some of those vasomotor disturbances. So the first thing I'm going to talk about is a non-pharmacologic therapy with some data, and that's physical therapy and occupational therapy. Now, the Journal of Hand Surgery essentially came out and said this is beneficial for some patients, and essentially it should be continued until the resolution of the disease if it does resolve. As I said, some patients never resolve when they live with this condition for life, and it is very excruciating for these patients, which really does lead to a very poor quality of life. So the whole goal of the physical and occupational therapy is to prevent late joint contractures. Essentially, we're trying to prevent that myoclonus that you see in some of those pictures that I had, where patients' hands become very contracted, their ankles or feet become very contracted, and we're trying to prevent that because that can lead to significant pain also. Unfortunately, there's not a whole lot of evidence to support that physiotherapy is beneficial. However, it is commonly employed, and there is case studies to say that it is beneficial in some patients. Not that it's beneficial in all patients, but it does help some. Outside of preventing these late joint contractures, really this is going to be used to help to maintain an active and passive joint range, again, to prevent that myoclonus that is commonly associated with the um, chronic regional pain or chronic complex regional pain syndrome. Another thing that is commonly used that oftentimes we will see in conditions like phantom limb pain is mirror visual feedback. So a lot of times when they do this, it is beneficial, but really most of the benefits are in the acute phase. So 8 weeks up to 1 year, there is some analgesic benefits, and they can be very immediate. There have been studies to assess this all the way up to a year. However, if they have had this disorder for a very long time, there's been very, very little data out there to support that it has any benefits outside of possibly a placebo effect. There's no change in pain levels, and there's no change in range of motion using mirror visual feedback. And again, mirror visual feedback is essentially retraining your brain to assess how we can connect our brain to our muscles to help to control our different movements. One medication that probably has some of the best data is gabapentin. And there was one study that I pulled that assessed 58 patients with CRPS1. And unfortunately, most of the data that we have does look at patients that have the subtype of 1 as opposed to subtype of 2. So this study was a placebo-controlled washout study. So they did look at both patients with gabapentin and placebo. They had a washout period, and then they swapped them. You can see here by dosages, they went up to 1,800 milligrams, which is typical for what we would consider treating with a patient with neuropathic pain. And you can see here by the graph that the gabapentin did have some improvement and much improvement to a much higher extent than the placebo in both the first period and post washout period. Now, the percentages that reported pain relief does include both the first and second periods of this study. So we do see there is a statistical significance in pain relief in these patients that were treated with gabapentin of 600 milligrams 3 times a day. And also, even though placebo effect did have some pain relief, it was not anywhere near the effects that gabapentin was used. Patients used co-medications during this initial assessment and during the baseline assessment. However, between the groups, it was very similar between what medications they were using in addition to gabapentin. So that wasn't necessarily a big compounder in the gabapentin versus placebo study. Another thing that's commonly used or commonly has been assessed is dimethyl sulfoxide and N-acetylcysteine. So there have been 2 studies. One of them looked at DMSO and NAC versus placebo, and the second one down on the slide just looked at DMSO. So essentially what they did is they took 146 patients and compared DMSO to NAC versus the placebo. So they didn't compare them versus each other. They compared each of them individually versus the placebo. You can see the dosages here. The DMSO is a cream that is applied 5 times a day, while the N-acetylcysteine is a medication that's taken PO 3 times a day. Now, they did have pain medications that were accompanied, and they didn't really say which pain medications they were, and they didn't give percentages. However, what the results of the study were found was that they are both beneficial. Typically, the DMSO is more beneficial for warm CRPS. So this is something we would typically consider more in the acute phase of the chronic regional pain syndrome. However, if they have developed to the later stages of CRPS, it would probably be more beneficial to attempt to try N-acetylcysteine first, because it was found to be more effective in cold CRPS, which is typically found in the later stages. They also assessed and study with DMSO 50% in 29 patients. And what they found is that there was an average pain decrease of 3 points. Now, patients were also on alternative therapies outside of the DMSO, so it's not necessarily to be used as an individual therapy or first line by itself. However, when added to other therapies like gabapentin, it has been shown to significantly reduce the pain. So some other therapies that I'm going to talk about that have some data, and I think Dr. Herndon can expand on one that I'm going to talk about a little bit more than I can, because there's not a whole lot of research out there, is ketamine. So ketamine is used often, or I shouldn't say it's used often, but it is becoming more oftenly used for this treatment. What the reason why it started to be used is because what they found is it was studied in mice, and it was very beneficial for developing or from preventing and treating CRPS. And another thing that's very beneficial is that they found that it was more beneficial for chronic CRPS. This is where patients get that myoclonic reaction. They can become dystonic. This is where the pain really develops, and this is where it really becomes a huge problem. So ketamine was found to be very beneficial in the later stages. Now, in the mice study that I mentioned, it was a 2 milligram per kilogram per day dose over 7 days, and they found that it did decrease the actual overall incidence of pain in these mice. So also, outside of giving ketamine through IV infusions, it does have some data as a compounded cream. There was one study that assessed looking at ketamine cream that was compounded with pentoxifylline, clonidine, and DMSO, and it had been shown to reduce allodynia associated with CRPS. Not only that, even though this study only included 13 people, 9 people did report significant pain reductions, with 2 of them having complete resolution of their pain when using this medication as a cream. IVIG, so intravenous immunoglobulins, have also been used. In the study that I found, unfortunately, they didn't really give a dosage of IVIG that was given. However, since this condition is a very complex condition that both has central and peripheral mechanisms, it has been shown to help to reduce pain in some of these patients. So it's still a route that is being studied more often, but it still needs quite a bit of data. And as far as NSAIDs go, they are similar, that they need more data to IVIG. And that's because they haven't been used as much as they probably should have been used. Now, the important thing with that is that typically NSAIDs and corticosteroids are going to be more beneficial in the acute phases of CRPS, where inflammation is typically more prominent. Typically, when you get to that chronic stage, the inflammation is not as prominent, and then the NSAIDs and corticosteroids likely would not be as beneficial. One of the other class of medications, which commonly we see in neuropathic type pains, is anticonvulsants. So as I mentioned, gabapentin is one, but the ones I'm talking about more is carbamazepine or oxcarbamazepine. There has been studies assessing carbamazepine, which did show a good statistically and clinically significant benefit over placebo. However, oxcarbamazepine has not been studied. Also, as far as like antidepressants go, the SNRIs have not had any good data to support use, which is another medication that typically is used with chronic pain conditions that is associated with neuropathic pain. Another one with like TCAs or those kind of antidepressants, they also don't have a whole lot of good data to support use. So opioids are obviously going to be another option, but with any condition, it's going to be kind of weighing the risks and the benefits of these medications to assess whether it is really beneficial. And a lot of times it will be put on opioids, but the data that I had found isn't really promising for that. It's putting a Band-Aid on a problem that doesn't really fix the root source of the problem. And as we know, opioids can induce opioid-induced hyperalgesia. So in the long term, these medications could potentially actually exacerbate the pain as opposed to actually treating the pain, especially in chronic pain or chronic complex regional pain syndrome. We could make the problems worse than they actually already have started prior to opioid therapy. So that's pretty much the overview of my complex regional pain syndrome. And if anyone has any input or therapies that they have seen success with outside of what I've used, I would love to hear your opinions.
So Brad, this is Chris. The ketamine infusion issue that you had brought up is, the reason that there's not great data out there is that everybody is doing something different. The dose that they're using is different. Some institutions are doing a flat, maybe 200 or 400 milligram dose over 4 or 6 hours. Others are doing weight-based. They all are looking at similar types of outcomes, but how they push the dose of the ketamine varies greatly. Some of the institutions will try to maintain the patient in a communicative state where they're able to talk and communicate back and forth with the person observing their infusion, but perhaps they report feeling a little outside of themselves or going along with the dissociative effects of the drug. Other places are trying to push the drug right up to sub-anesthetic doses, where they're not necessarily practicing, administration of ketamine in a conscious sedation type standpoint, but are really flirting closely with that. And so, a lot of institutions or hospitals are very leery of allowing their providers to do this type of therapy. And so what we see happening is there's chronic pain infusion centers that are popping up all over the country, where all they do is IV ketamine and IV lidocaine infusions, because so many hospitals are kind of shying away from that, and because also the insurance companies and payers are frowning on it because it's considered to be experimental. What data we do have is pretty tremendous as far as the outcomes are concerned. And so what's happening right now is just last week, the CRPS folks, the RSDSA, convened a consensus panel to try to come to some type of agreement on what should we be doing. Is it a 4-hour infusion? Is it a 6-hour infusion? What's the dose? Ketamine is never just ketamine. It's always going to be ketamine plus, a benzodiazepine, or ketamine plus clonidine. And so, then the question becomes, or what are the adjuvants that have to be given with the drug to prevent some of the ketamine-induced adverse effects? And another thing that I don't think we talk about very frequently is when we look at ketamine's use long-term, and this is more in the abuse population, but the development of only bodies, which are, I'm not sure I could even explain it correctly, but it's basically CNS changes that occur in the brain with long-term high-dose NMDA antagonism. So I don't know. I don't know what the future holds for that drug, but it certainly looks promising, especially based on some of the information you provided.
Yeah, a lot of the information that I've seen, unfortunately, it doesn't seem like there's a whole lot of case reports that I had found, but it seemed like, at least previously, before probably some of these newer institutions have started instituting ketamine use, was that the dosages they had required to achieve pain relief were pretty high and pretty scary high. And I think that scared a lot of people off, and probably why it's just now starting to become more at the forefront of therapy.
Any other comments or questions? You'll have to unmute yourself if you'd like to chat, or we have a chat function as part of the Zoom recording that you're welcome to use. I think we can all see that as well. We'll give folks just a second to figure out the technology. And
I'm still trying to figure it out as well. So.
I know, me too. The price tag is right on it, though.
Yeah.
Have you seen any CRPS in your hospice practice? I know we have a few in our chronic pain population, but
I have not seen any yet. So I guess it's fortunate that we haven't, because it seems like a pretty debilitating disorder.
Oh, it's awful.
So far, no, we haven't had any patients that I have seen when I've been here that have had CRPS.
Interestingly, Illinois just added it to their medical marijuana list of approved indications. All right. Well, the peanut gallery is silent today. Well, Dr. Rea, thank you for another phenomenal presentation. I think this has been the most informative for me, because it's so gray what's out there and how to help these patients. It's such a difficult pain disorder to treat. And for those of you who joined us late, you're able to access the full recording of this presentation on the Society of Palliative Care Pharmacists website. And please stay tuned for next week's presentation, which I believe is actually going to be done by some of our colleagues from Florida. looking at nausea and vomiting at the end of life. So I'm excited to hear that, and hopefully we'll see everybody back next week. Have a wonderful weekend.